Hello, everyone, and welcome to the Down Syndrome Center podcast. As always, I am your host, Dr. Kishore Volodi. Now, you might recall from the dark days that we know as the COVID era, back when we were in the midst of the pandemic, we had a certain someone that we would call upon, and that you guys, even when I see you at national conferences, say, "Is Dr. Nowalk here?" As if we're like one person. But we are not. We are, in fact, two people. But it has been a bit since I've had Dr. Nowak on the podcast, and a lot, unfortunately, has changed since July 2023 when we last did a podcast just looking at vaccines in general. And boy, has a lot changed. But before we get to those specifics, Dr. Andy Nowak, do you mind introducing yourself, who you are, what you do, and say something nice about one of your children if you could?
I think I shall. Well, thanks again for the invitation, Kishore. As you said, I'm one of your colleagues here at UPMC Children's Hospital of Pittsburgh. My name is Andy Nowak. I am an infectious disease specialist here at Children's. So my specialty is really treating and especially preventing infectious diseases in children, especially in children who are medically complex. And my connection to the Down Syndrome Center and the Down Syndrome world is through my son, Peter, who just turned 20 years old and
Hey!
has Down syndrome. Like most kids with Down syndrome, has the baseline stuff that comes with Down syndrome and infections. He had lots of ear infections when he was a kid and lots of sinus infections, and now also has some of the autoimmune diseases that go with Down. So he has celiac disease and he has type 1 diabetes and hypothyroidism. And so all of those things are things that keep us focused on trying to keep him as healthy as possible, which is why I'm so
Yeah.
excited we get to talk about vaccines.
Yes, because back in July 2023, when we were talking about vaccines, really it was just a matter of making sure how important families knew how important it was for especially children with Down syndrome to stay up to date and on time with the vaccines. And we're going to talk about that a little bit here during the podcast, but there has been quite a few changes that have come out in the last many months from our current administration and the way that they view vaccinations and the way that it's changing the way that many of our patients and families oftentimes will look at vaccinations. So one of the things I wanted to do today, Andy, if it's okay, I thought maybe we could go through some of the changes that were made and kind of get your perspective as an infectious disease doctor and also someone who has a loved one with Down syndrome. Kind of what are your opinions on some of these changes and how might a family interpret it? The first thing I want to talk about was when we're thinking about vaccines, it used to be there was a vaccine schedule and you adhered to it. But now there's something called shared decision making that shows up in many of these vaccines that we're going to be talking about today. What is shared decision making and how does that apply to vaccines?
Well, Kishore, shared decision making is really not a new concept. It's always been something that we have done around vaccination, which is that we need to make a case as a provider about why a vaccine is important to keep your child healthy.
Hmm.
So that's been going on as long as we've had vaccines. What has changed in the last year to year and a half, especially, is that now families are in a harder place. And I really want to emphasize that families are the ones who are dealing with a lot of this. We doctors still have the same really effective vaccines at our fingertips. But what families are hearing are different messages from the doctors that they trust who are in the room with them and the federal government. And that I just want to comment on very briefly is not because the vaccines have changed.
Hmm.
It's because the federal government, the leaders of the places that make vaccine recommendations have changed. And in particular, right now, the leadership of many of those places, particularly the Center for Disease Control, the National Institutes of Health, and the Department of Health and Human Services, those leaders are very suspicious of vaccines in a way they haven't been before. That
Hmm.
doesn't change the fact that the vast majority of all physicians that you run into still acknowledge that vaccines are one of the safest interventions we've ever had. But it's motivated these folks who have been in charge of some of these parts of the government to change recommendations, not based on evidence. And by evidence, I mean based on clinical trials and research where we compare the rates of diseases in children with vaccine and without, and we study any of the side effects of the vaccines, but based on more their opinion that they are concerned that vaccines aren't safe, despite the fact that we have a lot of data. So parents have been in a really difficult situation. They're hearing mixed messages. They're hearing from the practitioners in front of them that none of the data that they use to recommend vaccines has changed, but they hear different things from the government so far as the government actually has changes in the vaccines that they recommend. And then to make it more complicated, if you go a little farther and just look at what all the major medical societies in the United States recommend, including even some state health departments in a number of states around the country, they haven't changed their recommendations at all. So when you say shared decision making, what we're talking about is how we in a room talk with you about these changes and these challenges and how we get good information to you as a parent to allow you to make great, healthy choices that protect your child.
That's really a great way to think about it. And I agree with you. I think the families are the ones who get stuck in the middle now between what used to be very trustworthy and evidence-based information now becomes more opinion. And one of the opinions that just overall, before we talk about the specific vaccines, one of the opinions was that, well, if you look at all of these other countries all across the world, they don't have as many vaccines on their schedule as we once did. So isn't it good that we're aligning with these other countries?
So, what an interesting question that has come out there. And what I would say to that is the reason for the US schedule is that number one, we have both the information about what happens in the US in terms of diseases. So we know the epidemiology, that is how often certain diseases happen, which dictates some of our vaccine schedule. You know, if I have a patient in Pittsburgh with a fever, I think Pittsburgh diagnoses. If I have a patient who's just returned from India with a fever, I think about some things like typhoid fever or malaria. I might not think about Pittsburgh. Geography is destiny in infections. And so many of our vaccines are targeted to things that are happening in the United States. But a second piece is we have the luxury of having a healthcare system that has lots of resources. So many of the other countries make their decisions about vaccines based on their budget. And so they don't have private insurance and they don't have the degree of wealth that the US has. And so we have access to vaccines that some of these other countries have. And some of them, based on economics and other things, have made different decisions about recommending individual vaccines. I can tell you that my colleagues in those countries would come over to you and tell you the same thing. The US schedule is the ideal schedule for the US, and it's based on preventing the maximum number of infections in our country. And that's definitely the reason for the differences in these schedules, driven by the frequency the diseases happen, but driven also by the availability of resources, which we should be happy about. We shouldn't be
Yeah.
throwing away.
Yeah, I agree. And one that has come under fire in the news media who as they interpret some of these new recommendations that are coming, one is the hepatitis B vaccine. Hepatitis B is one that, we think about when we come to think about like transmission via the blood or via sexual activity. And yet, this is a vaccine that we've historically recommended to give right at birth and then follow up with the boosters after that during infancy. So one of the things that I've heard from the current administration is that, well, why are we vaccinating babies against a virus that won't infect them?
So that's a really good example of some of the thinking that's going on that I disagree with
Hmm.
categorically.
Hmm.
You know, one of the things I just want to share with people is we started doing hepatitis B vaccination in order to protect way more children. Children can't choose to be infected with hepatitis B. And one of the easiest ways for a child to get it is through an infected mother. And not all mothers get screened appropriately before birth. And so turning it into we're going to just take the risk with an infant that their mother may have been infected and we didn't know, and the infant will get infected, seems to me to be a really callous way to design it. Is it true that the majority of babies are not exposed to hepatitis B at birth? Absolutely. But we give a number of vaccines like the polio vaccine when the risk is very low, simply to maintain really good community immunity. And I think this is a good example. But we don't want any baby with a potential birth exposure to hepatitis B to get infected, knowing that the vaccine is almost 100% effective at preventing that baby from getting hepatitis B, which in infants is a really strong predisposition to going on to chronic infection in the liver and later in life liver cancer. And
Hmm.
so it's true that the significant minority of babies need hepatitis B, but why not protect everyone? And I'll just also point out, too, that in the US, our blood supply is really safe. But there's always things that can go on and accidents that can happen. And our kids with Down syndrome are much more likely to get medical procedures and therefore blood products and other things in the first year of life than children without Down syndrome. It's just the nature of a population that has a lot of heart disease, a lot of intestine disease, malformations, and other things that require correction, often life-saving correction. And when you go into a hospital, that's a place with blood products and lots of people involved in your care, where though the risk is really low, it's not zero. But you know
Hmm.
how we can make that risk zero for a baby getting hepatitis B? Vaccinate them, because the
Hmm.
vaccine is so effective. So I understand the putative arguments, but the putative arguments are really, they boil down to, it's okay for us to put a number of infants at risk of getting hepatitis B, and in fact, letting them get it, but because we can spare the other infants a shot at birth. And so that just doesn't seem sensible to me. That's like saying, we know very few infants will get into a car accident on their way home from the hospital, comma. Therefore, they don't need a good car seat the first time they go home. It doesn't seem evidence based to me.
Yeah, no, I completely agree. And I think that's one thing that's missed many times in the lay discussion of this vaccine is that the risk starts really right at birth. The acquiring it potentially from mother, and the only way to protect that infant is really vaccination.
And
And
a mother, to
yeah,
highlight it, Kishore, a mother
yeah,
won't know. She
yeah.
won't know the vast majority of the time that she has hepatitis B in her bloodstream. It doesn't give you a sign, nor
Hmm.
does hepatitis C most of the time. So moms won't know. And this is really relying on us to be able to absolutely identify every single time a mom with hepatitis B is giving birth to an infant. And I don't want to take that chance.
Yeah, yeah. So hepatitis B, I think you've made a good point. I mean, and it's a very serious condition, and it can potentially be something that could lead to chronic issues long term with that baby.
Absolutely. Yeah.
But then what about something like rotavirus? Now, rotavirus, when I was a resident, and when you were a resident too, Andy, was something that kept us very busy in the hospital because rotavirus causes diarrhea, often in younger children. And there was a vaccine that came out that has been tremendously effective at reducing rotavirus. In fact, now the current residents are probably like rotavirus. I don't know if I've ever seen one of that. And so it's an effective vaccine, but I've heard people say, but it's just a diarrheal illness. Dr. Nowak, why should we vaccinate against it? Why not just let the children have diarrhea?
Well, you know my long line here, Kishore. I mean, we give vaccines at the time we give vaccines to infants and children because that's when those diseases typically injure and kill those children.
Mm,
So it is, quote, just a diarrheal illness, unquote, except it put thousands, hundreds of thousands over
mm,
the years of children in the hospital every year with severe diarrhea and dehydration. In resource poor settings, rotaviral diarrhea was one of the common causes of infant mortality. It's staggering how dangerous this disease is. And every year in the United States, children would die from rotavirus. Not a lot, right? I mean, we have really good hospitals and we have really good ambulances and we have really good pediatricians like you and your colleagues. So, not a lot of kids would die. But I just don't know why it would be acceptable that any child would die from a common diarrheal illness when we have something that will protect them.
mm,
So, I just can't emphasize this enough. We give it at the time of life when we give it because that's when we would see those kids die from rotavirus. And
mm,
even if only a few of them were dying, we can prevent those deaths. It goes back again to seat belts and car seats. We put those on children because we can prevent serious injury and death with a really simple intervention, and that's rotavirus. I have to say, when I saw some of the information about what people were saying about why we don't need that vaccine, I was flabbergasted at that. I mean, you and I took care of kids who were really, really ill from
mm.
rotavirus, and we would see deaths every year in the United States. This vaccine's been life saving, like all of them are.
Yeah. Now you talk about life saving, and one of the vaccines that also became one of the topics of making it more shared decision making rather than required is the meningitis vaccines that exist.
Sure.
Um, and one might say, meningitis is pretty rare. Yet another thing that probably our current trainees are like, I've never really seen meningitis, or maybe I've had one or two cases. So is it really common enough for us to require or recommend a vaccine against meningitis? Or should it just be kind of optional, like it's being kind of touted now?
It's very interesting that the conversation about meningitis has gone the way it's gone.
Hmm.
Meningitis is uncommon. You read about it in a newspaper before, back when there were newspapers, or you hear about it on the news. You hear about an outbreak at a college, and it always seems very distant. But in the United States, for bacterial meningitis, typically caused by a bacteria we call Neisseria meningitidis, we would see hundreds to low thousands of cases a year. And so the vaccine reduces those number of cases by about 80% in teenagers, and especially. We've known for years that meningitis happens most frequently in teenagers and young adults because you often will get a lot of them together in the same place who've never met each other, and they will at college or in a dorm or in a military barracks swap bacteria because they're living around each other, and they're sharing drinks, et cetera, et cetera. And then we will see cases of meningitis, sometimes little outbreaks of them in those populations. And so we recognize the problem is this meningococcal bacteria kills a lot of the people who get it. So the mortality rate from this, despite advances in medicine, hasn't budged in the last 30 years. About 10 to 20% of patients who contract this bacteria die,
Hmm.
period. And they often die before they get to a hospital. So this is a lethal bacteria. So it gets down again to, hey, how many dead teenagers are we willing to have? They say shared decision making because they're like, it doesn't happen that often. If it happens to your teenager, that's enough for me in that
Yeah.
respect. And I do want to point out that quietly, while the CDC has changed their guidance, if your child enrolls in the military, there will not be shared decision making for them when they enter the military. The military is still going to give meningococcal vaccination to every recruit that comes in if they haven't had it, because the military absolutely believes that we're not going to sacrifice one recruit to a curable disease. And
Hmm.
that's striking to me. The US military is looking to protect us, and they think the best way to protect their recruits is to give all of them this vaccine. So just keep that in mind that, there's a little bit of dissonance even at that level when we talk about meningococcal disease.
And Andy, I'm sure you've seen this too. What I found is that as we get more and more uh, of the talk around vaccines not necessarily being needed or helpful or reducing the numbers that we give, we start to see even vaccines that have not been touched by the current recommendations being avoided by parents. Things like the measles, mumps, and rubella vaccine. And as you are quite aware, I'm sure that we are in the midst of a measles outbreak in this country, like has not been seen in decades. And I just wanted to get kind of your thoughts on just this measles in general. Is this vaccine something that families should say, well, if the rest of them are being questioned, we should be questioning that one too?
Yeah, I mean, I think this is the ripple effect that's coming out from a lot of these vaccines. And it's really hitting the ones that people have asked me about for years, like the measles vaccine. Ones that people will sometimes dismiss, like the flu vaccine, which is still a really effective vaccine, as well as ones that have been more controversial, like the COVID vaccines that still work, and the controversy is probably not warranted. I would simply say that this is the real danger of working at the trust that we have built up in vaccines in our society over time, in that what it produces is the diseases come back
Hmm.
inevitably. And we're seeing that. We're going to have more measles cases this year than we have had in 35 years.
Hmm.
That's a long time. And what happens when we have a lot of measles is what happened in 2025. Children die. We had 3 deaths from measles in 2025, really four, although the fourth one happened in a state that refused to report it as a measles death. And that is equal to the number of deaths from measles in the previous 10 years in the United States combined. And those are 3 children who were healthy and inevitably did not need to die from measles. And
Hmm.
if we had been rigorous about keeping our vaccine rates up, they would not have died. I'm a pediatrician and I'm a father. that's a tragedy for me. And so the fact that we're seeing vaccination rates for everything fall at the same time is a real challenge for us because we want to keep our communities safe and we want to do everything we can along the way to do that. So it's a real challenge, and
Yeah.
we're going to have to redouble our efforts as physicians to really drum up the support for vaccines that we had before.
Yeah. What about something like human papillomavirus or HPV vaccine? One thing that the current recommendations have changed is that instead of recommending two doses, they're now recommending only one. And I give it to you from a two-pronged approach. One is that the right way to do it? Is one enough? And then two is that many times families of people with Down syndrome will say, well, my child has Down syndrome, so their risk of getting something that's sexually transmitted is going to be low or zero, I've even heard some of them say. Thoughts on either of those two ways of looking at it? Is one dose enough? And is it different in somebody with Down syndrome?
So one dose, here's the thing about HPV vaccine. It's a really good vaccine. So one dose is going to confer some protection, but optimal protection, the highest level that prevents the most disease, is going to come with two doses.
Hmm.
So right off the bat, while they didn't stop recommending the vaccine, which I was pleased at, they weakened the recommendation, and so more people will be susceptible. So I disagree, obviously. And that wasn't based on evidence. That was based on personal opinion, which is not normally how we have done things before in the States. But the question of HPV is a sexually transmitted disease, I would just say HPV is a transmissible disease because we always think about the sexually transmitted part of it. But remember, human papillomavirus can be transmitted lots of different ways, simply by kissing, simply by any exchange of saliva. And we know now, absolutely, that there has been an increase in the last 30 years in the United States in head and neck cancers driven by HPV. And that increase has been going down a little bit with routine vaccination of teenagers because this is an anti cancer vaccine. Yes, it prevents cervical cancer from sexual transmission of HPV 100%, but it also prevents almost as many head and neck cancers from innocent transmission of HPV. And unlike cervical cancer and unlike warts that way, you often won't know that you've had acquisition of HPV in the head and neck. You don't typically get the wart lesions that you would see below. So when I think about this vaccine, yes, it's important for sexually active adults to have it because it prevents cervical cancer, it prevents anal cancers, it prevents genital warts, which, is a very terrible disease for a lot of people. But I'm also focused on the fact that even if you would say, my child is never going to be exposed that way, so I don't have to worry, you know, they kiss people goodbye. They see people in their family who may be shedding HPV. Why not reap that benefit too, which is going to be a big part of the societal benefit that we'll get from that. I had a friend about 15 years ago get head and neck cancer driven by HPV in his 40s. He had a real rough time with that.
Hmm.
Could have been prevented if he was vaccinated around the time he was a young adult. We just didn't have that vaccine. And so I made that point to my friend. I said, the sad thing is, if we had that vaccine, you would never have gone through this cancer chemotherapy and your family never would have had to be worried about you.
Yeah. Yeah. And I think that, just specifically even to Down syndrome, I think one of the things I often will say to families when this comes up is you have no idea what the future of your child with Down syndrome or your children without Down syndrome have. And you don't know consensually or even unfortunately non-consensually whether there will be the time where the virus might be able to be spread through sexual transmission as well. And so I think that we're limiting the futures of our thoughts of our futures for our friends and loved ones with Down syndrome if we think that they may not also have sexual activity in some way in the future for them. So I think that's super important for us to remember. Andy, when we just think about vaccines in general, sometimes people will say, well, we're always talking about how the immune system for people with Down syndrome is less effective in certain ways than it is for people who don't have Down syndrome. So then the question becomes, if we're vaccinating them, aren't we causing them potentially more harm because their body's immune system can't react to the vaccines?
So, what a really interesting argument about the kids with Down syndrome that they can't react to vaccines. You know, we designed vaccines at baseline to be safe. they are really, 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 really safe products. And they are more rigorously evaluated than almost any other medicines that we have because we give them to so many people. Um, we certainly know that the immune systems in children with Down syndrome are not perfect. But many of the things that cause them to get frequent infections are actually not from the components of their immune system. It's from the components of how they're made and how they grow. They get a lot of ear infections, much more so because their ear canals are more narrow and they don't tilt the right way, and their sinuses are very small and have very small exits. Then they have it because of their immune system. But we know their immune system doesn't help perfectly. So, what that makes me want to do is to boost their immunity. And that's what these vaccines do. We have very good data to say that kids with Down syndrome can respond to lots of different vaccines appropriately. The only problem is every now and then they don't respond quite as much, but that's why the guidelines that you and your colleagues have put together around vaccination and Down syndrome try to, where we need to give extra doses to give them extra immunity. So
Mhm.
this argument that I've heard that, maybe their immune system really couldn't actually handle it, that's not true at all. These are really safe vaccines. And if anything, you should be asking your practitioner, what are the extra vaccine doses I could give my child to keep them very, very healthy? Sometimes we'll do that with making sure they have influenza vaccine. So often we'll do that with bumping up the amount of the pneumococcal vaccines that they get, the PCV20, and in the future, the PCV23 and 24. So there's a lot of ways that we boost it, but absolutely they can get vaccines. They're never too weak to be vaccinated. And in fact, the vaccines may be something that'll reduce some of the issues they have just because of the way that they were born.
Yes. Yeah, their immune systems definitely seem to make it more difficult for them to fight off infections. So exactly,
Yes,
to boost these immune systems so they are more effective at fighting off the infection when they do get it. For example, on the hospital wards all over the place are my friends from Down syndrome clinic who are here with the RSV virus, which is
sure,
very,
sure.
very difficult on their lungs, and also things like the influenza virus and the COVID virus. Andy, many of these we have vaccines or things that can help prevent infection. Um, Thoughts on the way that I think now these have also become more of a optional, you don't really need to give these vaccines, for flu, for COVID. Thoughts on how we would approach that for somebody with Down syndrome?
Well, I think I would approach them with a lot of eagerness to get my child vaccinated.
Yeah.
Hey, look, we know a lot about Down syndrome and we know a lot about what causes issues with children with Down syndrome. And there are many of the things that come from having Down syndrome, certainly congenital heart disease, as so many of you listening know about, and intestinal diseases, as so many of you listening know about, neurologic issues and others. But what you and I see kids in the hospital for so frequently with Down syndrome is simply respiratory viral infections, putting them in the hospital with pneumonia and other complications. And so when you talk to me about RSV is a really significant disease of the infant. And if you don't have Down syndrome, you're still at risk. But we have really excellent data to suggest that infants with Down syndrome and even older kids, but especially infants, are really at very high risk from RSV, much, much worse than their non Down syndrome peers. And
Mhm.
so there's a lot of urgency to try to protect them if we can, especially given the risk of congenital heart disease, which makes RSV even worse than just having Down syndrome. So
Mhm.
if you're out there and you're listening and you have a loved one who has a child coming with Down syndrome, that's a mom who should get vaccinated to donate some antibody to her baby. And that's a baby who we should think about giving the antibody products that are available at birth to prevent disease. And I wouldn't be surprised if we might keep giving some of those antibodies and vaccines to kids as they get older in our Down syndrome population because we know it's so bad. And if you take everything I just said about RSV, you could replace RSV with COVID. And the same things apply. We know for some data that we've been working on here and looking at that we know that COVID by itself is an independent risk factor for really severe disease in people with Down syndrome above people who don't have Down syndrome. So the COVID vaccines, which we have, which are safe and effective, really should be considered in all kids with Down syndrome. And again, change COVID to flu. And the same data is out there. We know that pneumonia is a really big problem with children and adults with Down syndrome. And in fact, you and I know, we've talked about this a bunch of times. The number one killer of adults with Down syndrome is not heart disease, is not cancer. It's just pneumonia. And that
Mhm.
is every country on the globe that's ever looked at it. So, what's a really common cause of severe pneumonia in kids and adults? Influenza or flu. You know what we
Mhm.
have? We have a vaccine that reduces the severity of flu. And you may say, wait, hey, Dr. Nowalk, I heard on the news the other day that the new flu vaccine was only 25% effective. And I'm just making that number up. It's actually a little bit more this year. And so
Mhm.
only 25% effective. And that means only 25% of the time will my loved one with Down syndrome not get influenza because they were vaccinated. But what I will tell you is that's true, but that's really limiting your view of what the benefits are. We know that if you're vaccinated and you get influenza, that you are much less likely to need to go to the doctor. And if you go to the doctor, we know that that vaccine is going to make it much less likely you need to go to the ER. And if you're in the ER, it's going to make it much less likely that you're going to get admitted to the hospital, much less likely that you're going to go to the ICU, and much less likely that you'll die from that influenza. So even though we focus all the time, and this is our problem, we always report it in terms of efficacy, like how often is it going to absolutely prevent you from getting the disease at all? We don't advertise nearly enough that if you get it, the vaccine, but you get the disease, the vaccine modifies the severity of disease dramatically and protects you even in that scenario. So, a really good vaccine there too. And then finally, I think I've been on the show before a number of times to talk about pneumococcal vaccines
Mhm.
because the number one cause of bacterial pneumonia, not viruses, but bacterial pneumonia, which can happen by itself or on top of a virus, has always been pneumococcus from about age 1 month to about age 100 years. And
Mhm.
so pneumococcal disease can be very severe. And we know that the newer pneumococcal vaccines are incredibly effective at reducing the risk of severe pneumonias in every age group that they're given to. And we have really, really, really good evidence that kids who get pneumococcal vaccines protect the adults around them. And as it turns out, the adults around them can protect the kids that they care for as well. So it goes both ways here. And it's a really important benefit that we need to pay attention to. So these are all diseases that are about pneumonia, but pneumonia is so common in our kids with Down syndrome that this is a really critical area where we need to protect them as much as we can.
Yes, and Andy, when you bring up that pneumococcal vaccine, like we were saying earlier with the MMR, that people are avoiding it because they're just questioning all vaccines these days that we're running into. The same thing with this, with what we call Prevnar, with the brand name, but pneumococcal vaccine. The ear infections, the sinus infections, or pneumococcus, pneumonia, pneumococcus, all of the things we've been talking about on this podcast. But then I've had several of our families that have had beautifully thriving, well, great developing babies, happy, and then they did chose not to vaccinate, and the babies end up getting this pneumococcal bacteria in their bloodstream, or bacteremia, we would call it. It goes in their bloodstream and it goes from there everywhere, including causing meningitis. So it's a really severe disease, and those kids are never the same afterwards. And again, like you've been sharing, it's so preventable. And so it's why when families ask me in clinic, do you think we should vaccinate our baby? I always say absolutely. And I try to do what so many of us don't do as well, which is share stories of the fact that we've run into this situation where somebody who was not vaccinated ended up having an outcome that could have been prevented. So, Andy, I appreciate you highlighting that for us today. Are there any other things that you want to make sure you leave our listeners with, or any summary that you want to give us today of any of these things that we've talked about?
Uh, Mostly that I'm so sorry that they're caught in the middle.
Yeah.
I really I feel for them because this is a very strange time to have, um, these changes to the vaccine schedule be out there and then have you and I on a podcast saying, hey, they may not be the right thing. That puts parents in a difficult position. Um, and if those changes were motivated by the fact that the evidence had changed about these vaccines, then I might be a little bit more willing to consider it. But they're not motivated by that. They're
Hmm.
motivated by folks' personal feelings about things. And you know, in our business, what we try to do is we try to look at all of the data and the evidence and try to let that tell us what's going to do the right thing for kids with Down syndrome. And all kids, but we're talking about kids with Down syndrome today. And so when there's an intervention, and there's new interventions for kids with Down syndrome all the time, you know, we study it and then we say, hey, does our guideline need to recommend this? Because this will protect kids. And I think it's very telling that when you look at a lot of other bodies that are really concerned about the health of children in our country, the American Academy of Pediatrics, the American Academy of Family Practice, even the American College of Physicians, which is for internal medicine, even though they don't take care of kids, they take care of adults and they care a lot about vaccines. All of those bodies have said we are not going to follow the recommendations made by the CDC because they're not based in evidence. So, you know, we talked about shared decision making at the beginning. What I would do is if you have doubts and you listen to this and you're like, well, I just don't know. What you should do is sit down with the caretaker you have in the Down syndrome community or your pediatrician or family doctor and ask them. Ask them what they know about the reasons the government changed that and if they think that they're going to follow that or if they're going to follow the old schedule, which had not changed for years substantially because the evidence behind it was really strong. You know, I recognize that, you know, when people say, well, other countries don't give as many vaccines as we do, therefore they're right. Um, that's a really deceptive argument. Other countries look different in the different kinds of diseases that happen there, and they have limitations on their resources. We have the ability to protect our kids broadly. We should go ahead and protect our kids. And I measure how well we protect our kids by how we protect those of us who are most vulnerable. And that starts in my house with my son, Peter, and the fact that he has Down syndrome. And so I'm going to measure how well we're doing by how I'm protecting Peter. And I'm going to protect Peter by following the old schedules because they still work and that evidence is still good. And I'm going to continue to do that. And I'm going to hope that people in the government will come to their senses and realize that we're putting kids at risk with these changes. And
Yeah.
opinion shouldn't put kids at risk. Only data should drive our changes.
I love it. Thank you, Andy, so much again for joining us on the podcast and sharing your expertise and your obvious passion on this topic. I think you've got two doctors on this podcast who love people with Down syndrome and would not want any changes to come that would impact their health in a negative way. And so happy to be able to share this information with you. So, Andy, thanks for joining us again today.
Anytime, Kishore, and I hope everybody out there is staying safe and getting through the respiratory season, which is always a tough one for our community.
Oh, for sure.
And yeah, I'll come back anytime to talk about vaccines. You know that.
All right, we'll take you up on that offer. And to our listeners, if there are any topics that you want us to cover on this podcast, please do reach out to me at Down Syndrome Center at chp.edu. And if you'd like to contribute to what we do here at the center, including this podcast, please go to givetochildrens.org/Down Syndrome Center. But until next time, bye bye.